So what is a normal intra-abdominal pressure? Well, that's between 5 and 7 millimeters of mercury. So how are intra-abdominal hypertension and abdominal compartment syndrome defined? Well, first thing to think about is that the abdominal perfusion pressure is the map minus the intra-abdominal pressure. So if this thing rises, then the intra-abdominal pressure falls. So that's the perfusion to the abdomen falls. So intra-abdominal hypertension is any intra-abdominal pressure that is greater than 12 millimeters of mercury. And we can actually go on further and break it down into stage 1, which is 12 to 15, stage 2, which is 20 to 15 millimeters of mercury, stage 3, which is 21 to 25, and stage 4, which is greater than 26 millimeters of mercury. Now, intra-abdominal hypertension is an intra-abdominal pressure of greater than 20 millimeters of mercury with or without an abdominal perfusion pressure of under 60 with evidence of at least one organ failing. So intra-abdominal hypertension is an intra-abdominal pressure of greater than 12 millimeters of mercury. Grade 1 is 12 to 15, 2 is 16 to 20, 3 is 21 to 25, and grade 4 is 26 millimeters of mercury. And abdominal compartment syndrome is defined as an intra-abdominal pressure of greater than 20 millimeters of mercury with or without an abdominal perfusion pressure of under 60 that is associated with new organ failure. We can also say that ACS, or abdominal compartment syndrome, is primary or secondary. And primary is due to abdominal pathology, and secondary is extra abdominal. So primary is abdominal and secondary is extra abdominal. So, risk factors for abdominal compartment syndrome. Well, we can break this down to decreased wall compliance, so a rigid abdomen, increased abdominal content, a capillary leak, and then other things. So decreased wall compliance, tight surgical closure, trauma or burns needing escherotomies, obesity and being proned. All of those will increase the wall. And then there's abdominal contents, and we can break that down into intraluminal and extraluminal. An intraluminal ileus, gastroparesis, pseudo-obstruction. Pseudo-obstruction affects only the large bowel, whereas ileus affects both the small and large bowel. Extraluminal could be ascites, hemoperitoneum, or a pneumoperitoneum. Capillary leak, well, it could be from sepsis, trauma, acidosis, a large transfusion, and a positive fluid balance. And there's other things: mechanical ventilation, PEEP greater than 10, increased sitting up, and shock or hypotension. So we can break that down into the risk factors for intra-abdominal hypertension are decreased wall compliance, such as a tight closure or proning, increased abdominal contents such as an ileus or extraluminal things such as ascites or bleeding, capillary leaks, and then other miscellaneous things. How do we measure it? Well, directly, such as in surgery, or we can use indirect transducers, and the commonest one is the bladder. And in the bladder, you have a catheter. You put 25 mils of saline into the bladder, clamp it off, and then you have a needle into the port site, which is transduced to a strain gauge, and the whole thing is zeroed at the symphysis pubis. So what does intra-abdominal hypertension do to other things? So if you have raised intra-abdominal pressure, there's all sorts of ways it can manifest. So you get atelectasis, basal collapse, pore expansion, and therefore VQ mismatch. You get reduced chest wall compliance, and you end up with low O2 and a high CO2. And then you may give PEEP to help, and that worsens venous return. Cardiovascular problems, well, increased IAP will decrease venous return. So there was a reduction in cardiac output because your stroke volume is going to go. And then because you've decreased your cardiac output, you will actually worsen your intra-abdominal pressures. And if you increase thoracic pressures, you actually increase splinting. So you make respiratory function worse and you make cardiac output even worse. Kidneys, well, you just reduce perfusion, and this will activate the renin-angiotensin-aldosterone system. And then GI, there is reduced hepatic flow, and then hypoperfusion of the bowel, which leads to edema, and you get biliary stasis.